good morning, everybody, and hi, and thanks for joining our town hall today. I'm Dave McKeag, the EVP of Corporate Affairs and CFO. As you would be guessing by now, I have the privilege of acting as a bit of an MC for today's session. Please don't provide comments back to Aaron about how he was so badly missed. I miss him already. We'll go through quite a few topics today. So just a reminder, as we go through the session, there's a couple of ways that you can pose questions. One is to raise your hand using the raise hand feature in Zoom, and you'll be called upon in sequence. The second, of course, is to write a question in the Q&A, and we would please ask that you do put questions into the Q&A rather than the general chat box. And when posing a question, we'll answer as many as we can, and those that we can't, we'll be sure to provide an answer onto the hub after the fact. So with that, I will begin this discussion with our land acknowledgement. We are privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. I would also like to bring to your attention that September 30th is Orange Shirt Day and Canada's first National Day of Truth and Reconciliation, such an important topic. You'll be hearing more about our plans to mark this at HHS in the coming weeks. So moving to the agenda, as you can see, there's a few more items on this agenda. We do have a lot to talk about. We do have an operational update. And of course, we'll get an epidemiology update. And as we're facing wave 4, I'm sure we'll have keen interest in hearing about that. Also of keen interest will be the provincial mandate for vaccination policies that has recently been announced, and how HHS is planning to deal with that, as well as a recruitment update. And also want to mark the vaccination. Now, when it says vaccination update and thank you to staff, we're referring to our own efforts as an organization to provide a vaccination clinic. Lastly, we'll get a bit of an update about Project Odyssey and an exciting opportunity for all staff to be engaged in the Go Live experience if they wish as a super user. And lastly, we'll go then to live Q&A and celebrations. So lots to hear and talk about today. Again, encourage your participation and questions in the Q&A box. And I guess at that point, we will throw it to Sharon, our EVP of Clinical Operations and COO, and she'll take us through the beginnings of the operational update. So over to you, Sharon.
Hi, welcome everyone today. And on behalf of Rob, who can't be with us today, sending his greetings as well. It's really hard to believe that we're in this last stretch of summer. And someone said today we're just 4 short weeks till the fall, which is really hard to believe. And it has been one busy summer. I think everyone would attest to that. Much of the summer, we have been balancing the challenges presented by the pandemic. We have continued to care for COVID patients, although the numbers lower than what we've seen in wave 3. We've been working very hard to ramp up on our surgical and procedural activities as well across our sites. I think most are well aware we've been dealing with significant HR pressures. The pandemic has had a significant impact across our organization. We know there are finite resources across the sectors, certainly within Canada, North America. We read a lot globally about these pressures. Our schools and our training centers have not been able to graduate the number of students we typically are used to receiving. And there's significant demands in the community and the sectors, the home and community, the primary care, the acute care sectors, all have demands related to the pandemic, which is resulting in really a very difficult time from a recruitment perspective. And on top of this, we have our regular attrition that we would expect. So there's a lot of attention and a lot of focus on this in our organization right now as we work through our recruitment strategy and retention strategy to ensure we can continue to deliver the care that we need to. So thanks to everybody. I know you are all managing through very challenging times right now. With respect to the COVID, we continue to monitor what's happening with the Delta variant and with wave 4, and Dominic has a really fulsome update for us this morning as well. And as always, our best defense remains the vaccination. As Dave referenced, on Tuesday, the provincial government did direct hospitals to implement a new vaccine policy by September 7th, and work is underway about what will be expected and shared in the upcoming weeks. And Michelle will update us in a few minutes, but please keep in mind that we are just working through our implementation policy after just receiving this news this week. If you want to see the release specifically, it is posted on the hub, along with details as to where you can continue to receive your vaccination. And again, we would encourage you to please report your vaccination status to Employee Health Services. So with that, I'll switch over and provide a bit of an operational update in terms of how we were doing. So this very much like my updates that we regularly have here. But as far as ED goes, we have seen a substantive, or what I would consider a substantive, increase in our ED volumes of almost 10% this month. And that's certainly translating to pressures within the department with high numbers of admit no beds, and certainly higher occupancy pressures than we would like to see. And again, having pressures on capacity and staffing. Our ALC volumes have also started to increase, which we did anticipate to some degree as long-term care home capacity is maximized as well. But we do continue to have the satellite health facility available to us. It is available at this point till the end of March, and we're very happy with that. And we look at every opportunity to maximize the beds that we have available there to us. There's other areas that we're feeling the pressures. In June, I reported our labor and delivery volumes were high, and June was the highest on record, and now July is the highest on record. So we continue to see volumes within that service drive higher than what we're used to, along with trauma. We're in a very busy trauma season as well. And there's many other areas across the organization that are feeling the inordinate pressures of activity right now. We did open the UCC on April 3rd, very happy to do that. We will resume full hours in September within the UCC as well. If we just go to the next slide in terms of where we're at as far as our capacity in COVID, ICU, not unlike every other ICU across the province, is extremely pressured. Occupancies are high. Again, staffing particularly challenged in these areas. With respect to current status, you can see now there's 19 COVID or CRCI patients in the 11 in the ICU, and there's 17 remaining on the ward. We continue to provide the ECMO program. We've talked about that program previously. Really is a service or an intervention that is in high demand as a result of COVID, and is a particularly resource that requires a lot of staffing and clinical support. So again, thanks to the team that's managing that program within the ICU. And just noting, because we've reported it previously, is the number of patients outside of our region, which really there's only 2 left from the census balancing activities that we are involved in as part of the provincial capacity planning. And so I think that's it with respect to my remarks in the operational update. And with that, I'll hand it back to Dave to keep us moving through the agenda.
Thanks, Sharon. So much underway with trying to provide care for our community, and a lot of pressure on the organization does continue, for sure. Next, we're going to hear from Michelle Leroux, who's going to provide us some updates. In particular of interest, I'm sure, is the provincial direction around required mandatory vaccination. So Michelle, if you could update us on that, please.
Thanks, Dave. And as Sharon mentioned, this is relatively new, so we're doing the best we can to provide you with information in a timely manner. And I think you could check the hub probably daily, and there'll be so many updates coming your way. So there is a new directive, as we've seen. Work is underway to implement that directive at HHS. We're working with our regional partners. The emails are flying, definitely, to make sure that we get information to you in a timely way. At a minimum, this directive requires that staff, physicians, contractors, learners, students, and volunteers do one of 3 things. And again, that's at a minimum: provide proof of full vaccination against COVID-19, and full vaccination is defined and likely subject to change as we see things like booster shots and different things in the media. Provide written proof of a medical reason for not being fully vaccinated, or undergo regular testing. There's also an educational component that you'll see in that directive, and more to come definitely on that. We also at HHS, and really across the region, and you'll see it already existing in a number of hospitals, we're considering mandatory vaccination for new hires as we implement this vaccination policy, and also looking at what we can do for our visitors and family members and caregivers around this vaccination policy. The directive is pretty clear about the requirement of the hospital to comply, to track, to report. So significant work underway before the September 7th deadline. On the next slide, what can you do between now and, as I mentioned, September 7th, but you will see in communications coming out shortly, we're aiming for September 1st for mandatory reporting. So we've got about half of our staff and physicians right now who have reported their vaccination status. I cannot ask you enough, and you'll hear it throughout this presentation. Please report your vaccination status. We encourage everyone to be vaccinated. The link is there on how to report, and it's also on the hub and in various communications. So again, let's get ahead of that September 1st date. Let's have some better numbers about our HHS community. We are looking at volunteers and other groups that are outlined in that directive and how they might report. So stay tuned, more to come for that. But right now, when we look at staff, physicians, and our learners, we've got this ability to track and to report, and we've been doing great. And I think we can even do better. So I'm going to kind of turn topics for now and move on to a little bit about our staffing environment. We could probably do 2 hours on this topic, and it's not really fair to call it recruitment or staffing. It's a bigger issue, but again, as Sharon mentioned, there's challenges with HHR supply across the province, across Canada, regionally. It's not unique to HHS, but HHS is our concern, and it's about our people. The demand is outpacing definitely what we can, particularly in nursing, but not just nursing. There are a variety of different other roles that we are struggling to recruit. There's so much work being done, and I wish we could bring more visibility to this, and this is the start of that. There's work being done within the clinical programs. Kirsten and I are constantly connecting about the academic and other areas, interprofessional practice, NRT, finance, and HR. Just know that it's an organization-wide priority, and a lot of work is being done to understand and try to address it, knowing that this is an issue that is bigger than just HHS. So we've got some strategies. Some of the strategies for specific areas have unfortunately been a bit delayed with the pandemic, you can understand, but we're dusting those off and moving forward. So what can you expect around recruitment efforts, knowing that it's challenging and we just don't have a lot of people out there looking for employment right now? Well, we've got tools and training programs coming out because it's a different environment. And you'll recall here, we're very decentralized in how we recruit. So we've got some tools and tips and tricks to help the programs and our leaders recruit, because it's very different than when you could wait for a posting to close and have 100 candidates to choose from. Again, great work done by much more than just HR about calling all nurses. It was held in July. We've got more planned. Anything all of you can do to remind people why it's great to work at HHS and why to join us. We've got great partnerships with our academic partners and more underway. We're thankful again for the partnerships with Kirsten's team and others that are helping us move that forward. If we can retain our externs that come to HHS and our new graduate staff, that's a wonderful stream for us to have as a recruitment tool. And there's different strategies, like I mentioned before, for specific areas, some regional strategies, some HHS strategies. But in the end, if I was to sum it up before I turn it back over, I saw this picture the other day about remembering that the shortage is everywhere. So for the people who are here, let's take the time to be kind to them, to be thankful for them, especially in our areas where we're short, like the ICU and other areas. Let's be thankful for everyone who comes in every day to be here for our patients, and take care of each other. And with that, I'll turn it back over to you, Dave.
Okay, thanks, Michelle, for that. And lots more to come for sure about vaccination policies. Lots of questions coming in the Q&A, and maybe I'll just comment. A couple of them have been answered, but some we're still sorting through ourselves. And as soon as we get more information, we'll definitely be sharing that in the coming days. So at this point in time, we'll turn it over to Dominic, who will take us through what I'm sure we would all like to better understand what's happening with Wave 4. So Dominic, over to you.
Yeah, thanks, Dave. That's the epidemiology from back August 4th, so the last time that I presented on this. And on the next slide, you see the current status. So across Canada, the case numbers per 100,000 per week increased from roughly 14 to 38 over those couple of weeks. So certainly a significant increase in terms of case numbers here. On this slide, as usual, you see for each province the case numbers per 100,000 per week, and you can see that it's mostly our provinces out west, including the territories at this point, that have the highest case numbers per population. And you also see red arrows there that their RT is clearly above 1. So they continue to see an increase in case numbers. Manitoba, currently with the lowest numbers outside of the Atlantic provinces. We are sitting at 22 with a slight increase at the current pace, and lower at this point of time than Quebec, as you can see here. Next slide. That's the epi curve. The black line is where I sort of expected us to end up this week. Now growth seems to have slowed down, at least when looking at the last 3 days. So we might be a little lower than that. But when we compare that to where we've been last year, it's somewhere between mid to end of September 2020 in terms of case numbers per 100,000 per week. Next slide. Hospital admission wise at the provincial level, you see a slow increase from another couple of weeks ago. We are currently comparable to where we've been back in October. Then I will show you the Hamilton data later. We see more of an uptick. Next slide. This is our Hamilton EPI, and behind Windsor, we are currently the public health unit with the highest numbers per population. However, also our growth has leveled off a little bit. So we continue to be in that range of somewhere between 40 and 50 cases per day, but we saw a significant increase over the last week, that's for sure. Similar to what we've had last year in October with that first bump until we went fully in the third wave, into the third wave here. So we are currently comparable in terms of case numbers to what we would have had end of October locally. Next slide. In terms of hospital admissions, as I mentioned, we see more of a bump here already. We are comparable currently to December 2020 within the city of Hamilton. And you can also see that roughly 50% or even more than 50% of those hospital admissions are on the ICU. And that's pretty much what we expect to see in the fourth wave. Just to maybe mention that now, while we had a very small proportion in the ICU in the first wave, a little bit larger in the second wave, then a significantly larger in the third wave, we expect that proportion to even become bigger, because we expect that, and I will come back to that, that it will be more that 20 to 60, 70 year age range that will be presenting to hospital, and those are either doing well and stay at home. If they need hospital admissions, it's unfortunately often that they require ICU level of care. So probably that proportion will remain in that 50+% range. Next slide. The provincial models, we don't have any new models since June 10. Again, just probably the last time that I'm showing this figure here. We certainly overperformed in terms of driving case numbers down until I would say early August, and since now we see an increase. While the curves from back in June sort of expected never to go that low, but then continue to get lower. But this is certainly influenced by public health measures, by Delta, and many other things, and also the vaccination rates that haven't continued within the range that we would hoped for. So if we had continued with what they assumed here with 180,000 vaccines per day, we would be in a much better situation. It would be less of an uptick at this point, most likely, as predicted in those models. Next slide. So these are the local models as they had been shared publicly last week. You see 4 different scenarios here. The worst case scenario, the dark blue, where we would expect roughly 20,000 patients between last week, that would be at the end of the year, would assume that we don't get any higher than 70% of people vaccinated, and with reduced public health measures. The best case scenario, the one at the bottom, the yellow, which basically means we would be planting this or putting the fourth wave pretty much back to bed, would have assumed 80% vaccinated and to maintain current public health measures. Most likely the truth will lie somewhere in between those two extremes. There's a lot of moving targets, a lot of unknown, a lot of uncertainty, particularly if you're looking forward over several months. And you can see 1 week after those models came out, we already are off the chart with a higher increase than expected, and we will see those models being adjusted along the way. And then the further we go in, the less uncertainty there will be, at least for the short-term predictions. Next slide. In terms of hospital admissions, here again, those 4 scenarios, and you can see that with the best case scenario, we would continue to see a decrease in hospital admissions, which obviously doesn't happen. We do see an increase already. And again, worst case scenario, we would see something similar to the 3rd wave in terms of hospital admissions. If we get those vaccination rates up, we will be able to make this 4th wave much more bearable for us. So again, really the key piece to push this back will be to get 80% plus people vaccinated. Next slide. This shows you the age groups, and I already touched on this. On the left-hand side, you see the reported cases by age group, and you can see that the vast majority of the cases, roughly 70%, will be in that 20 to 60 year age group, and only 10% will be older than 60, and only a very small proportion older than 80. And around 20% will be less than 20. And then on the right-hand side, you see how this will translate based on current vaccination rates to hospital admissions. And you can see that kids, we expect responsible for roughly 5% of all hospital admission. The majority will be in that 20 to 60 age range, then followed by the 60 to 79, despite the much lower case numbers. And then the 80 plus will still be responsible for 10% of hospital admission, despite the fact that it will only be roughly 1% of cases, just because of what we've seen over the last few couple or 3 waves at this point, because of the underlying comorbidity and their risk to have severe COVID. Next slide. And finally, death. Again, worst case scenario. Not even the worst case scenario, I would say here, predicts as many deaths as we would see in the 3rd wave, which you see on the left-hand side here. So the worst case scenario would expect 68 deaths until the end of the year. The best case scenario, only 9. The last death we have had was August 4th. So far here we are following pretty much what the model would have predicted, but expect to see an increase going into October, November. Next slide. Now, where are we at with those vaccines, given that I told you that in particular for hospital admissions, eventually this will be the main factor that will play into to what extent our hospital system will be strained. And as I showed you with the science table models, those assume that there will be a higher uptake of vaccines going into August, but we saw a significant drop, and I showed you that already. At the provincial level, 81.6% of 20 plus have had at least 1 dose, and 73.7% have been fully vaccinated. Next slide, you can see the Hamilton data. We are sitting at 77.9% and 69.8% respectively. So on the next slide, you see the comparison. So in terms of single dose, we are lacking behind 3.7% compared to the provincial average, and even a little bit more on the next slide for the fully vaccinated with 3.9%. So we certainly have to, or can, catch up hopefully with most of the other public health units that tend to have higher vaccination rates than us. But we are talking about a few percent difference. It's not that it's like 10+% difference. Next slide. And these are our 7-day average of vaccines administered in Hamilton. And you see that by mid of July, we certainly had a significant decrease, much stronger decrease than we were hoping for in terms of number of vaccine administered each day. And you can see that we are now below 2,000, relatively stable throughout August. And the hope clearly is, with all the additional mandates or motivators also that are out there in the community at this point, that we may be able to increase the number of doses per day again, with the eventual goal to get this fourth wave into a shape of a wave that will not strain our healthcare system as significantly as the third wave. Next slide. What to expect when you're looking globally, and this is a very busy slide. So there are certainly countries which are on the same trajectory as we are. We are just lacking behind here. So that the top one shows you the number of cases per 100,000. And you can see that of the countries that I chose here, we are the lowest in terms of case numbers per 100,000 at this point of time, but all the countries are increasing. I added my home country, Switzerland, here, which is further up than as you see in the United States, that continue to increase. And in particular, Israel, that I showed you previously as a great example how they kept the Delta wave first under control, and now they are struggling. On the other hand, some good news from other countries on the next slide, countries that seem to be able to control that fourth wave. Again, just as a comparison, Canada here at the very bottom in purple, but we have Iceland here, which seem to have plateaued, which is a highly vaccinated population, much higher than us. Netherlands, that had a huge peak, you can see that in the green, the very large peak that you can see. They came up as quickly as they went down afterwards. Portugal seems to have plateaued. Spain is coming down now, and the United Kingdom, which seems to have like a biphasic wave. So they had this large increase first, and then, as you may remember, they had their so-called Freedom Day. They opened up everything, despite the fact that they were in exponential growth. And against all expectations, actually, their curve came down, and now it looks like they grow, or the case numbers are growing very slowly but steadily at this point, but not to the same extent that they would have grown early in summer. So bottom line is, when you're looking at what happens globally, you see very different patterns, and this adds to all that uncertainty in terms of what can or should or have we to expect locally. And I think it goes back to prepare for the worst and hope for the best. Next slide. Now, in terms of preparing, looking at community transmission, and I showed you that previously. So this excludes all your outbreak cases, which we have very little. We have very little outbreaks compared to the previous waves or early waves at this point, and excludes everyone who had a known close contact. But as you may have read in the media, we have currently the largest proportion of our cases are unlinked. So we don't know where they picked it up. So out of our 40, 50 cases a day, roughly 40% are unlinked. So we don't know where they come from. And then if you do the math, you see that we are in that range of 20 per 100,000 per week. We peaked above that. Currently, we are pretty much sitting at 20, which we said in the past. It's our threshold to implement the non-low epi policies. And given that at this point, we expect the case numbers to increase further rather than to come down. Next slide, please. We decided to do so again and switch our policies to the non-low epi policies. And this will happen over the next few days, next week. So there's no urgency. As I said, it's not that the cases locally are exploding, but we certainly see that direction at this point. So one of the pieces will be, again, restarting pre-procedural testing for surgeries that require intubation or other major surgeries, such as hip replacement, but only in unvaccinated patients from Hamilton and Windsor Essex, which are the two public health units that are currently above that 20 per 100,000 per week threshold. It will include, again, COVID testing of patients with symptoms with an alternative diagnosis. So that's your patients with fevers and appendicitis. We want them to get tested for COVID, while over the last couple of months, we would have said, don't bother, epi is low, and you have a good explanation for the fever. And then the broader use of N95 or HCMPs. So basically going back to most of the policies that we have had in the second and third wave, with some exceptions, which will be that we don't do as much asymptomatic testing in the vaccinated and in the unvaccinated folks. And one of the questions in the Q&A was, why aren't you testing vaxxed staff as well? Because we do see breakthroughs, and I think the examples given were the US and UK. Yes, we do see breakthroughs, but it's still 6 to 10 times lower risk than in unvaccinated to have a positive test. Plus the other piece that I wanted to respond to live, and I may do right now rather than at the end. One person said, well, we now know that that vaccinated are as likely to transmit as unvaccinated. And that's a misunderstanding of the literature out there. So yes, you can have a similar CT value, so a similar bioburden in vaccinated as in unvaccinated, but you have that for the shorter period of time. And when you look at the epidemiologic studies, it's relatively consistent that a fully vaccinated individual infects less people than an unvaccinated would. So please be careful and not try, and I know some media did that. They saw those CT values being the same in the two groups, and based on that surrogate marker for infectivity, they concluded the risk of infection is the same. It's not the case. To the best of our knowledge at this point, the risk of transmission from a fully vaccinated individual is still significantly low, in the range of 6 to 10, to the best of our knowledge, than in an unvaccinated. And that's the rationale behind some of those policies. Handing back to you, Dave.
Thank you, Dominic. A lot of information to take in as we shift as a world into wave 4 and battling the variants. And it's certainly got us keeping our eyes open and concerned, rightfully so. I guess at this time in the agenda, we're going to hopefully pivot to a bit more of a thank you and a discussion on still vaccines, but we're going to turn it over to Bruce to talk to us a little bit about the vaccine program and administration within Hamilton, and some great results there and some thank yous to be offered. So Bruce, over to you.
Yeah, thank you very much, Dave. And it has been some time since we've sort of talked about the vaccine program as you've described it in some of the details. And you know, today is a little bit of a pivot, I think, or to reflect a bit of how vaccine administration is pivoting. You know, I can say that since that last update, you know, we have seen some improvement, as Dominic has described. It's not as much as I think any of us would have hoped versus the last time we reported in September, but we are still making some progress. I can update even from what Dominic just presented, that as of this morning, in Hamilton, 78.2% of the eligible population has received the first dose. So it's gone up another couple of tenths of a percentage point, and 70.3% of that eligible population, that's 12 and over, have received a full vaccine series. And again, you can see the numbers provincially, and they do compare well to really the rest of the world and Canada. The nice thing about this slide, it shows just the variety of channels by which vaccines have been distributed in Hamilton, and this is true across the province. And where we've sort of ramped up one area, we've been able to ramp down another area, and that does include the HHS clinic. And so, if we go to the next slide, I want to talk a little bit about that. So, nearly 8 months ago, really a tiny bit over 8 months ago, HHS was asked to play the role as the inaugural vaccine site in Hamilton, and one of the first in province. And within less than a week, the 293 Wellington HHS vaccination clinic was stood up just a little less than 8 months ago. December 23rd, that very first dose of a vaccine in Hamilton happened, and the very next day we had the first doses to HHS employees. Those doses were directly administered by both HHS employees and physicians, and by staff and physicians from right across the health sector in Hamilton. So other hospitals, public health, primary care, pharmacy, long-term care, the list is so long. The list of who was involved in directly administering, but in doing all of the background work that led to setting up this clinic within a week, and to begin to distribute what in the end would be over 160,000 vaccines in arms to the people of Hamilton. And a reminder that the vast majority of HHS staff and physicians and our partners received your vaccine at this clinic. This clinic that was established in an administrative place, the HITS vaccine office at the 293 Wellington site, which is both a location for Bay Area Research Labs and Bay Area Trust, as well as I said, our HITS group, as well as other pieces. So it was a testament, I think, to our flexibility, our ingenuity, and most our ability to work together, and most critically, the skill, dedication, and devotion of all of our teams across every one of our areas. If we go to the next slide, again, a bit of a pivot. So yes, the HHS 293 vaccine clinic did close on August 2nd after delivering all of those vaccines, allowing us to pivot a little bit back to our other pieces of work. But that doesn't mean that that vaccine opportunity has been reduced. In fact, it still is extremely wide across the city of Hamilton. It includes your choice of vaccine. And so when you go to the hamilton.ca website, on a daily basis, you can see all of the different places where you can, if you choose, register to get a first dose or to get your second dose on an accelerated basis. It also includes the fact that you can walk in to any of those sites and just walk up and say, I'm ready for my vaccine. And so, while we're going to be moving out of the large clinic business in Hamilton at the end of this month, but both the West 5th Clinic and the First Ontario Centre, there will continue to be so many different mechanisms through primary care, pharmacy, pop-up clinics, mobile buses, school clinics starting this weekend, et cetera, where you, your family, your friends can go and get your vaccine. So you can see my message there. It's still available and accessible. Get yours. If we go to the next, the last slide. So I talked about kind of HHS pivoting out of the large-scale vaccination clinic business, but of course we continue to participate heavily. And we kind of think internally, we do continue to ensure that inpatients, particularly those en route to long-term care, are receiving their vaccines to facilitate our and their safety as they transition. We're also in the midst of a pilot related to ED patients at the Hamilton General. That's using our outpatient pharmacy at the General for those emergency patients. So really, it's an opportunity. Often with folks who are at quite high risk in the community, where the ED may be their only interaction with the healthcare system to refer them for vaccination. We're also in, and there's a large group working very diligently to develop a program to really facilitate checking in and supporting every single patient in an ambulatory visit, to ask on their status and to provide advice and where appropriate, referral to encourage their vaccination. You've already heard today about the government announcement on policy for vaccination in healthcare institutions and other areas. There were also announcements this week on booster shots. Booster shots, third doses really for, at this point, a very small number of high-risk health conditions, mainly related to severely immunocompromised patients, as well as for residents of long-term care, high-risk retirement homes, and elder care lodges. So that's just announced this week. More will be coming on exactly how that is going to roll out. The other thing they announced is that the age range has been slightly expanded. So now it's not date of birth for eligibility. You have to be 12. It's will you turn 12 in the year 2009, and at that point you'll become eligible. So if we go to the next slide, I'm going to transition over to you, Dave. But as I do, I'll just echo how incredibly thankful I am to everyone that has played such a role of diligence and dedication in these efforts over these past 8 months.
Thanks, Bruce. And yeah, I wanted to offer my own personal thanks for so much of the effort that I saw across the board. I can remember the days leading up to opening the clinic, and it felt a little bit like a war zone, with cable being strung, Cat5 cable being strung to provide additional security, and door lock readers and cameras and insulation all over the floors while we were setting up a clinic, all the way to providing thousands and thousands of doses to our own staff, to St. Joe's staff, and ultimately to the community. So it was an incredible accomplishment, and I wouldn't even try to begin to name people because I'll leave all the wrong people out of the list. But there were certainly, clinical and physicians and support functions like IT and HR and finance and all just such an incredible effort to stand up this kind of a clinic. The volunteers that called out at the beginning of all of this to spend hours of their own time in the evening to call out and schedule appointments. The list goes on. So just a huge and warm thank you for this effort and this response to our community and to ourselves, but in the battle against COVID. So just thank you so much. And Bruce, I don't know if you need to add anything there, or if that can cover it for now, but it was an incredible accomplishment and will long be remembered in the history of HHS, in my view.
I agree, Dave. Well said. Thank you.
Okay, so in the interest of time, we will keep moving along, and we have one last agenda item, and then we'll be able to answer a few more questions and some celebrations. So I'm not sure if it's Barry, Dr. Lum, or if Michelle Leafleur is speaking, but as the executive sponsor for Project Odyssey, I'm thrilled that we've been able to continue this work. It's such an incredibly important initiative towards better patient care, and we all always remember that in our work. But Barry, over to you for a bit of an update, if it's you.
Yeah, it is me, Dave, and thank you very much. And hi, everybody. So as Dave has said, I want to thank everybody for continuing to make Odyssey a priority as we ramp up activity in the project, and at the same time recognizing the healthcare sector's toughest period in probably living memory. We're 288 days away from go live of the project, and while all of this is going on, the Odyssey team and the rest of the organization has continued to work very hard on the project, and we have made tremendous progress. You'll see on this slide the long and winding road that we talk about. We've now moved out of phase 2, which is called the building phase, into this very critical next phase called testing. We will be obviously continuing to work every day to keep this moving. For anybody who kind of wants to look at this at any time, this graphic is available on the hub. Next slide. In the interest of time, I'll just point out that there are all kinds of pieces of the puzzle coming together as we have been working along. Some of you will be aware that we're launching the new Omnicell medication dispensing cabinets across the organization. And for those of you who will be involved in using those, I would encourage you to be sure your fingerprint is registered and that you're all set to go. I'm proud actually to say that HHS has embraced the idea of becoming a choosing wisely organization, which relates to improving the quality of the care that we provide, reducing duplication, and doing the best paths of care that we possibly can. And we are continuing to move forward with that. And there's a really cool piece called Secure Chat that you're going to hear about a lot more as we go forward, which will vastly enhance your ability to communicate with your colleagues at all levels in the clinical journey. Next slide, please. So you probably have also heard that training is an absolutely critical part of a successful go-live in Epic. We need to train 15,000 staff and physicians to be ready to go on June the 4th, 2022. And one piece of that at Go Live that's particularly critical is the at the elbow support that is provided to all staff as they begin to work on the new system. So super users are the folks who become Epic experts, and at Go Live will be at the elbow to provide that kind of support. And it's really a terrific opportunity for our staff to be the go-to person for Epic in their clinical area, and also to provide guidance to their colleagues during those first few days and weeks of the Epic Go Live. The super user is a temporary full-time assignment that will begin for the most part in April of next year, and then become a temporary full-time role at Go Live for up to 8 weeks. Next slide. So if this is something that tweaks your interest, or you know folks that you think would be ideal for this kind of role, we're beginning the process of identifying our super users by asking folks to raise their hand and submit an expression of interest to the project, and to let their managers know of their interest, so that we can begin to understand the level of support that we can count on in the organization for the super users at Go Live. So if you're interested, or you know folks who are interested who want to put up their hand, this is just now an expression of interest. There's no commitment, and we recognize that we're asking this in a difficult time, but I would emphasize that this is for next spring. Please go to the Odyssey page and look for the form, and it will come to us and come to your manager at the same time. And I believe I will pass on this slide, other than to point out that there are a whole bunch of key dates that are coming along, and you'll continue to hear from us on a very regular basis. Thanks, Dave.
Thank you, Barry, and lots more of exciting opportunities to engage in Project Odyssey and the deployment of Epic at Hamilton Health Sciences for the benefit of our patients and our staff and physicians. So lots more to come. It's very exciting what I've been able to glean and see so far. So at this time, we would move to Q&A, and there's a reminder, a couple of ways to ask your questions. One is the raise hand feature. If you would like to ask a live question, raise your hand, and we will be able to open up the mic for you. We, of course, have been answering questions live during the webinar in the Q&A chat box. And if we haven't been able to answer your question, rest assured, actually, thank you for providing all the questions, in particular on mandatory vaccine. There's a lot of questions that we've been answering, and I see many more in the Q&A chat box. So great that you're putting those forward, because we'll be able to ensure that we are issuing as comprehensive as possible an FAQ to go along with any of the materials that we're able to provide. And I will just say 2 quick comments there. One, I think a lot of the questions have been sort of answered live, and if they haven't, the notion here is we're still figuring this out just a little bit. So as and when we have some of the answers that are being asked here, we'll be sure to provide them. And the second quick comment I would like to make is just an ongoing, please get your vaccine. If you haven't done so, there are still plenty of ways and opportunities in the community to do that. And it is our best fight, particularly against the variants. So with that, I will see if there are any other questions that we would like to be able to answer. I believe there was one question that I saw that I can't now find. So let me see if I can find it. And if not, if there are any particular questions that you had wanted to answer live, I see Sharon popped onto camera, so she's going to save me.
No, I see a question there. Barry might want to answer in terms of can a manager put up their hand to be a super user?
I actually don't know the answer to that question, but I can't see why they wouldn't be, assuming, pardon me, assuming that they can be away from their clinical duties during that interval, and appropriate coverage for their important role can be identified. I would assume that we would be happy to look at that.
Yeah, thanks, Barry, and I would agree. And part of this process is to understand who is interested in being a super user. So if you are, please come forward, and as time goes by and into next summer or spring, as we look at responding to those EOIs, we'll make that determination in terms of identifying those staff that we're able to provide that opportunity with. So the long answer to say yes.
Thanks, Sharon. Thanks, Barry. So we have 4 minutes left. So I think we would want to make sure that we could have a few moments to be able to offer celebrations, as we usually do at this time in our webinars. And maybe I'll actually kick it off. If you don't mind, I'll take that purview for a moment. While I didn't mention it within the body of the webinar, I did want to also thank Bruce specifically. It's kind of something where it's a tiny bit thankless, perhaps, to all of the work and in behind the scenes that he did in leading a lot of the effort with vaccines and integrating with the public health unit of Hamilton, et cetera. So just I will offer that extra thanks to Bruce for all of his work. And he will be quick to say it was a team effort, as he always does, but I thought his name should be mentioned in that vein today. So thank you, Bruce. And I have already gone and done it. I should actually also thank Les Gauthier, who played a large part. There was a team at the beginning of this of senior leaders that had to get together on a very, very regular basis to figure all of this out. Michelle Leafleur in IT, and Michelle LaRue in Human Resources, Bruce, Les, and I, we all spent many, 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 many hours discussing this. So just a broad thank you to them and beyond. The list could go on. So I think I will stop there. So are there thanks
Michael
that we
has
can
popped up, Dave.
Perfect. Michael, over to you.
Dave, yeah, hi, look, thanks. Just wanted to take the opportunity to thank all the physicians who have stepped up during COVID, many of them working outside their normal scope to support those looking after patients on the ward and those in ICU, particularly the protected code blue teams. And, as our numbers have reduced and our activities have ramped up, many of them are needed back in their home disciplines. We still have a little requirement to need some of them at present in a protected code blue, but we quite possibly maybe leaning on them again for extra support. So just wanted to take the opportunity to thank them at this stage for what they've done and for what we may need to ask of them again. In addition, obviously, as already been mentioned, many of them helped out in the assessment centres and vaccination centres, and that work that they've contributed to has also come to an end, but wanted to recognise that, and also those that are continuing to support us in the satellite health facility. All of this is outside what would have been their normal scope of work. So just want to acknowledge that.
Absolutely. Thank you very much, Michael. I'm looking to see if there's any in the chat box or if any Les Gillies you have popped up. Why don't you go ahead, Les?
Thanks, Dave. Just wanted to acknowledge and thanks for everyone's patience and all the incredible work that was done by obviously all of our deployed staff, but most recently, of course, the sort of the delay, but the opening as of August 3rd of the Urgent Care Center, thanks to all of our interdisciplinary staff and administrative staff and physicians and so on. Looking forward to a full opening in September, but thanks for everyone's patience and support.
Perfect. Thanks, Les. I see Michelle LaRue, you have popped up. Go ahead.
Just a quick thanks. We're hearing lots of feedback within HR and in some of the work I'm doing with talking across the different sites. The people who are taking on extra work and doing everything they can to support their colleagues for taking some well-deserved vacation. I hear it over and over again that they are happy to go above and beyond because they know the person who's off on vacation that week really deserves it and look forward to their own vacation. So thank you to everybody who's supporting their colleagues to get some time off this summer.
Absolutely critical. Yes, agreed, 100%. Thanks, thanks, Michelle. Les, is that a legacy hand, Les Gillies, or are you back up?
I will take it off, Dave.
Okay, fair enough.
I think
Okay,
we
well,
are. Yeah.
I think we are at the end, Sharon, right? So,
Yes.
all right, well, thank you. A ton of content, lots to absorb. Keep your questions coming in. We're doing the best we can to make as quick decisions and provide information as we can on things as they come along, particularly lots of Q&A, as we said, around the vaccine, mandatory vaccines, et cetera. So stay tuned. Thanks again for joining us today, and we'll look forward to seeing you at the next webinar. And I hope you have a good rest of the day. Thanks, everyone.
Thank you.